Vanakkam. When there is a single soft tissue defect on a finger, the classical cross finger flap is a great choice for reconstruction. But what if there is a defect on the dorsum of the finger, or the stump of the finger, or the lateral side of the finger, or for that matter multiple fingers? The classical cross finger flap would definitely not fit the bill in these situations. So, do we have no simple and reliable choices? We do. The modifications of the cross finger flap. The modifications of the cross finger flap could be modifications in the design, modifications in the technique, and modifications in the donor finger. So many modifications that we are going to see in this video. We shall be using the classical cross finger flap as the standard from which our modifications will be discussed. Please click on the icon above to see the description of the classical cross finger flap. By modifications in the design, we mean the design of the flap will be different from the design of the classical cross finger flap. By modifications in technique, we will be referring to the flaps that are raised in the usual way as a classical cross finger flap, but with a little change. And by modifications in the donor finger, we mean the flaps are raised like a classical cross finger flap, but the donor finger is changed or altered. Under the heading of modifications of the cross finger flap in design, we will be discussing about 4 types of flaps: the proximally based cross finger flap, the distally based cross finger flap, the cross finger reverse dorsal digital artery flap, and the cross finger adipofascial flap. The proximally based cross finger flap is ideal for distal soft tissue defects mainly on the dorsolateral aspect of the finger, requiring a good quality skin cover which would allow future reconstruction or surgery. For such a defect, isn't it more conventional to use the reverse dermis cross finger flap or the cross finger adipofascial flap? These flaps need a skin graft over them, and hence the quality of the skin cover is reduced. So the indication for a proximally based cross finger flap would be resurfacing defects on the dorsum or the dorsolateral aspects of the middle or ring fingers, or the ulnar or radial aspects of the index and little fingers respectively. The ideal defect for this flap should be at the level of the proximal interphalangeal joint or even more proximal to it. This is because the distalmost edge of the proximally based cross finger flap is the distal interphalangeal joint crease on the dorsal aspect of the donor finger. This flap is designed with the base extending from one neutral line to the other neutral line on the proximal part of the flap, and the length of the flap is designed such that it would transpose comfortably to the recipient defect on the adjoining finger. This proximally based cross finger flap can be harvested in a 1:1.5 ratio. After the flap has been raised and inset given, when the dressings are done, a volar POP is applied to the hand as against the dorsal POP, which is usually applied after a classical cross finger flap. The advantage of using the proximally based cross finger flap for this sort of defect is that we can cover the defects on the proximal aspect of the dorsum of the fingers with a flap of good quality skin. But the obvious disadvantages are that a longer flap will have to be raised to allow it to transpose comfortably to cover the defect, and the bridging segment is longer than in the classical cross finger flap. The defect on the dorsolateral aspect of the middle finger has been covered with a proximally based cross finger flap raised from the index finger. The distally based cross finger flap is similar, but the base is oriented distally. The flap must be long enough to allow transposition to the defect, hence only dorsolateral defects are safely covered with such flaps. And after flap inset has been done, the donor site is skin grafted, dressings are done, and a volar POP slab is applied. The indication for such distally based cross finger flaps would be soft tissue defects on the dorsolateral aspect of the finger requiring good quality skin cover, and if these defects are distal, that is at the level of the distal interphalangeal joint, it is more ideal. Instead of grafted skin, it provides good quality skin cover for dorsal defects. But we need to remember that the distally based cross finger flap is not very reliable in the sense that it has got a limited arc of rotation and can be used only for dorsolateral aspect of the fingers, and that too for distal defects distal to the proximal interphalangeal joint level. Like in this example, where a distal defect has been resurfaced with a distally based cross finger flap. When dealing with the reconstruction of dorsal defects on the finger, there is another flap that is a little more reliable, that is the cross finger reverse dorsal digital artery flap. It is actually quite similar to the distally based cross finger flap, but there is a small modification in the design. You would have noted that the base of the distally based cross finger flap extends from one mid-axial line to the other, and the flap must be longer to allow transposition to cover the defect on the adjacent finger. So naturally it runs the risk of compromised vascularity of the flap and also limited arc of rotation. It would be ideal to narrow the base of the flap without compromising the vascularity, and this can be done by converting the distally based cross finger flap into an axial pattern flap. It has been proved that there is a system of arterial communications between the volar aspect and the dorsal aspect of the finger which occurs at designated levels, such as the neck and base of the middle and proximal phalanges. So, on both sides of the neck and on both sides of the base of the middle and proximal phalanges on the dorsum of the fingers, there are perforators from the volar aspect coming to the dorsum. One such example is shown here at the neck of the middle phalangeal region. The marking for this flap would be similar to that for a distally based cross finger flap, but the communication is marked and the flap can be almost islanded. The skin incision would be on almost all four sides with a small skin bridge protecting the vascular pedicle. It is not essential to skeletonize the vessel here. This way, a better arc of rotation can be achieved without compromising the vascularity. This flap can be marked either distally based or proximally based, pedicled on one of the communicating perforators. Though ideally indicated for the cover of soft tissue defects on the dorsum of the fingers distal to the proximal interphalangeal joint, this flap can be used for any of the defects on the dorsum of the finger. There is a better play of the flap movements and ability to cover more distal defects. The lesser length will be required of the flap from the donor finger, but it needs more care during dissection at the site of vascular pedicle. This shows a defect on the dorsum of the little finger on the middle phalangeal region, which has been covered with a cross finger RDDA flap based on the communicating perforator at the neck of the proximal phalangeal region on the ring finger. The flap inset has been done and the flap has settled well with absolutely good range of movements post-operatively. Now we come to the fourth modification in the design, the cross finger adipofascial flap. The technique of harvesting this flap is quite simple. The flap is marked just like a classical cross finger flap, with the base of the flap on the contiguous side with the injured finger and close to the defect. But this flap that we have marked is going to be under the skin. Now a marking is made of a similar size with the base on the opposite side neutral line. This marking denotes the dermal flap that is to be raised before the actual cross finger adipofascial flap can be accessed. This dermal flap is raised first at a plane just deep to the dermis, preserving the subdermal plexus. The flap is raised and opened like a book. Next, soft tissues covering the extensor paratenon are raised as an adipofascial flap in the same way that a classical cross finger flap is raised. This adipofascial tissue is then used to cover the defect on the injured finger. The dermal flap that was raised is now repositioned to cover the donor site of the adipofascial flap. A skin graft is now needed to cover only the soft tissues of the adipofascial flap on the recipient finger, and after application of dressings, the POP slab must be applied on the volar aspect of the hand. The second stage of division is done as for the classical cross finger flap. This flap is indicated for any soft tissue defect on the dorsal aspect of the finger at any level. It has the advantage that a skin graft is required only to cover the adipofascial tissue over the defect, and cosmesis is better on the donor finger as there is no skin graft as in a reverse dermis cross finger flap, and there is no possibility of inclusion cysts. But this flap has a few disadvantages. The adipofascial tissue is a delicate layer which barely covers the defect. It requires careful elevation of the dermal flap over the donor finger, and graft take is not optimum over the adipofascial flap. In this example of a raw area on the dorsal aspect of the index finger, the thin adipofascial flap is used to cover it from the middle finger. Now we shall see the modifications of the cross finger flap in regards to the technique. Under this category we shall see three flaps: the folded cross finger flap, the innervated cross finger flap, and the reverse dermis cross finger flap. The folded cross finger flap can be done when a patient with a thumb injury refuses a Littler's neurovascular iron flap, or a stump of an amputated finger needs to be resurfaced. Here, a small modification is made after elevating the classical cross finger flap. A back cut is made in the flap to allow the distal end of the flap to fold over and cover the stump and the dorsal aspect. Since this technique entails a back cut, it is important to remember that this may cut into the blood supply of the flap. Hence, it must be done carefully. As stated previously, this modification of the classical cross finger flap is useful when covering the tips of the finger or end stumps of the fingers after amputation. The advantage is it covers both the volar and dorsal aspects with a single flap. The obvious disadvantage is that the back cut can compromise the vascularity of the flap and result in partial necrosis on the dorsal aspect of the flap. Since the patient with this injury refused a Littler's neurovascular island flap, a folded cross finger flap was harvested from the dorsal aspect of the index finger, inset done, and after division we can note the well settled flap both on the volar and the dorsal sides. The main indication why innervated cross finger flaps are done are to ensure a good return of sensation to the tip of the finger. When the debridement of the wound is done, the cut digital nerve stump is identified and tagged. When the flap is being raised, the sensory twigs on the dorsal aspect of the finger are also identified and tagged. At the time of flap inset, the tagged digital nerve at the edge of the defect is coapted to the tagged sensory nerve on the flap with 10-0 polyamide suture. The second stage of the division is carried out as usual. The indication for this flap is for the coverage of soft tissue defects on the terminal phalangeal region of the fingers on the volar aspect to achieve improved sensation, and this will be the most important advantage of this modification of the classical cross finger flap, but it needs just a little more expertise in microneural coaptation. A typical defect on the tip of the ring finger resurfaced with an innervated cross finger flap from the middle finger. The reverse dermis cross finger flap is also a modification in technique from the classical cross finger flap. Here, the skin on the proposed area of the cross finger flap is deepithelialized, which is planned on the dorsal aspect of the contiguous finger. After deepithelialization, the flap is raised similar to the classical cross finger flap, superficial to the extensor paratenon. The flap is then hinged like a book, and the dermis side is laid over the soft tissue defect on the dorsal aspect of the injured finger. Now, the entire area consisting of the donor side defect and the flap over the defect site are then covered with a split thickness skin graft. After the dressings are done, POP application must be on the volar side to allow for quick monitoring and dressings of the flap. The second stage of division is done just as for the classical cross finger flap. This flap is indicated for coverage of any soft tissue defect on the dorsal aspect of the finger. The advantage of using this flap for reconstruction of such a defect would be that it is a simple procedure, and this flap contains tissue which is more robust than the adipofascial flap as it contains the dermis. But there is a possibility of developing inclusion cysts from the deepithelialized area under the flap, and a larger skin graft will be required to cover both the donor defect and the flap. Here is an example of a reverse dermis cross finger flap done for resurfacing a defect on the dorsum of the terminal phalangeal region of the index finger. Lastly, we shall see the modifications of the classical cross finger flap in the donor finger, and in this category we shall be seeing 4 flaps: multiple cross finger flaps, filleted cross finger flap, hugging cross-finger flap and the jumping cross-finger flap. First, we shall see the entity of multiple cross-finger flaps. When there are multiple defects on the fingers, there may be a modification necessary in the form of multiple cross-finger flaps. However, there are important points to be noted before planning multiple cross-finger flaps. The first point is that these flaps can be done only if the defects are in the terminal phalangeal region. Since the flap is harvested from the dorsum of the middle phalangeal region, if the defect involves the volar aspect of the middle phalangeal region also, there is a problem of making the wound circumferential, which must be avoided. The second important point is that the flaps can be raised one after the other and after the debridement of the wounds is over. Similarly, flap inset can be given and then the donor sites covered with skin grafts. The third important point to be noted is that these multiple flaps will involve increasing flexion of the interphalangeal joints in contiguous fingers. So it would be difficult to do multiple cross-finger flaps in patients who have short stubby fingers and also in elderly people with stiffness of the joints of the hand. So the ideal indication for performing multiple cross-finger flaps would be multiple soft tissue defects on 2 or maximum of 3 fingers involving only the pulp tissue of the terminal phalangeal region, preferably in younger individuals with long fingers and pliable joints. The obvious advantage would be multiple finger defects can be treated simultaneously with the safe and reliable cross-finger flap, but since it requires more pliability of the finger joints, it may not be advisable in some groups of patients, as we have already seen. Example of defects on the terminal phalangeal region of the ring and little fingers of a young man covered with classical cross-finger flap from both the middle and ring fingers with excellent post-operative range of movements. The filleted cross-finger flap is unique and can be used only in certain situations. When there is a defect on a finger requiring a cross-finger flap, and when the adjoining finger has been partially amputated with loss of the distal segment and revascularization is not possible, the injured finger can be filleted and the filleted skin flap can be used to resurface the defect on the recipient finger. So this flap would be indicated only in such a situation where there are multiple injuries to fingers and a partially amputated finger adjoining a finger with a soft tissue defect requiring a flap cover. And again, it should be stressed that it can be done only if there is no option of revascularizing the partially amputated finger or the patient does not want reconstruction of the amputated finger. This technique makes use of the tissue that may have to be discarded. The only disadvantage is that the partially amputated finger may by itself have a precarious vascularity, and using the filleted flap from this finger to cover a defect on the adjoining finger may not be very reliable. Here, a filleted flap from the partially amputated little finger has been used to resurface the defect on the stump of the ring finger. The hugging cross-finger flap is another unique modification of the classical cross-finger flap. Here, the recipient finger is placed over the secondary defect. Usually, in the classical cross-finger flap, the donor finger and the recipient finger lie side by side with no overlap. But when the defect on the finger is more on the radial side or ulnar side of the finger, the recipient finger will have to adduct towards the donor finger so that the flap can get a comfortable inset. So naturally, the recipient finger will come to lie over the secondary defect on the donor finger. This flap can be done only for defects on the radial or ulnar side of the terminal phalangeal region of the finger, and that would be the indication for the hugging cross-finger flap. In this position, the flap has got a comfortable inset to 3 sides of the defect. But again, in this position, there is some overlapping of the recipient finger over the donor finger, which may cause shortening of the volar aspect of the recipient finger, some graft loss on the donor side, and sometimes stiffness at the metacarpophalangeal joint of the recipient finger because of the deviation. This example shows a raw area on the ulnar side of the terminal phalangeal region of the ring finger resurfaced with the hugging cross-finger flap from the mid finger. Please note the ring finger, which is the recipient finger, lies partly over the donor finger, which is the middle finger, and here you can note the good post-operative results. Now we shall see the jumping cross-finger flap. In this modification of the classical cross-finger flap, the injured adjacent finger can be skipped, that is, jumped over. And this flap is used when there is an injury to the dorsal aspect of the adjoining finger and a classical cross-finger flap cannot be performed. So this flap is indicated when the defect on the soft tissues is restricted to the volar aspect of the terminal phalanx of the finger and the adjoining finger is so injured that it cannot serve as a donor for the classical cross-finger flap. But it is also important that the third finger from the finger requiring the cross-finger flap must be intact. The advantage is that this flap offers a simple reconstruction even if the adjoining finger precludes the use of a cross-finger flap. And as expected, this flap will involve slight deviation at the donor and recipient finger metacarpophalangeal joints, which can be corrected after the division of the flap at 2 weeks. The raw area on the terminal phalangeal region of the index finger requires a reconstruction with a cross-finger flap, but since the mid finger is already injured, the flap has been taken from the ring finger with good results.
I hope you liked the video. I enjoyed making it. Do click on the shown links to see more about other flaps used for reconstruction of the hand, like the groin flap and the stepladder abdominal flaps. And do not forget to subscribe to keep connected with the latest in learning hand surgery.